Thank you for joining us today. Today we are in session 4 out of 5 for our Taking the Pain Out of Pain Management series. And today we will be discussing non-pharmacological management of pain. Before we start, I would like to do a land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is a traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and more recently, the Mississaugas of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here today as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And the Palliative Care Echo Project. I'm sure the majority of you are already aware, but this is a 5-year national initiative to cultivate communities of practice and establish continuous professional development amongst healthcare professionals across Canada who care for patients with life-limiting illnesses. So we would like to thank Health Canada for financially supporting this project. Without their financial support, we wouldn't be able to do what we're doing today. So thank you. And now I would like to introduce our presenters. Today we have Nancy Good-Kennedy and Rachel Lepense who are both from the North Simcoe Muskoka Hospice Palliative Care Network. That's a mouthful. Thank you for being here today, ladies. It's so great to see you both.
Thank you so much. I'm just letting in 2 other people from the waiting room here.
Perfect. And while you do that, I will actually just do a couple of housekeeping items. We will be using the chat today, so please feel free to put any questions you have in there. And then also later on in the presentation, Nancy and Rachel will both be inviting you to answer some questions there as well. The floor is all yours, ladies.
Thank you so much, Amanda. On the screen right now, you'll see a QR code. This is going to be our survey following the end of the presentation. So you're welcome to scan it now if you wish and just hold on to it until the end of the presentation, and then you could complete the survey, or we'll also put it up at the end of the presentation as well. So whatever you prefer. So for the purpose of today's session, there's a few objectives we'd like to hit the mark on. One of them is, what is the objective of pain management? What are the desired outcome of non-pharmacological pain management? What are non-pharmacological strategies that we could implement to help relieve pain for our patients in our care? And why are non-pharmacological interventions important?
Okay, so let's get started. Let's talk about pain and what is pain. In follow-up to the definition that we have here, I'd just like to add that pain really is whatever your patient tells you it is, what their interpretation and what their intensity that they describe to you. So we use the classification of pain just as a reminder to you of the different classifications and the importance really of determining the etiology of that pain. Here's just a quick review of the types of pain. And I just wanted to really mention also that breakthrough pain may happen even when you are taking the correct amount of pain medicine and that current medicine is wearing off. For example, that would be the breakthrough pain. I'll turn it over to Rachel.
Thanks, Nancy. So pain management, whose responsibility is it? And we've mentioned this in some of our previous in-services as well. It takes a team to address the needs for pain management for an individual. And then some hospitals that are in a clinical setting, have doctors and nurses that specialize in pain management or palliative care, in addition to other specialties. In community, same idea. There are outreach teams that can address things like this, or community patients go into acute care to address issues. So the team may or may not include nurses, nurse practitioners, RPNs, acupuncturists, pharmacists, surgeons, internists, psychiatrists, psychologists, social workers, you name it. There is a multitude of disciplines that are involved on the team. So when we think about pain management and the plan, what sorts of things need to be incorporated into the plan? Certainly, we need to make sure that we've done a full assessment, and that full assessment would need to include what the descriptions of the pain are, what the symptoms of the pain are that the person is experiencing, and a physical exam from head to toe to see if what physiological issues are going on. And then that also most likely will include imaging, blood work, any additional tests that the medical team feels would be valuable to look at that entire picture. And then the plan also includes really looking at what has been used in the past, what is currently being used as far as medications. And when we say medications, those are prescription medications, but also just off-the-shelf medications or alternative medications that are maybe used not specifically for one reason, but an out-of-the-box sort of idea for a medication. So when we think about the etiology of pain medication, I want to leave you with this statement here. There's a growing appreciation for the psychosocial aspects of pain. This idea is growing for two reasons. One is that there's a greater awareness of the psychological factors that play a role in pain management. And second, because of the opioid crisis that we all know about and read in the papers these days. The evidence is variable for many different therapies that are non-medication related. And so Nancy and I are going to review some of the alternatives that can be used that are non-pharmacological ways in which people can treat their pain. And as I said, the evidence is variable, so it's up to you as the service provider or you as the individual to investigate some of these options. We're just going to give you a little highlight about them so you have an idea so that you've heard of them from this session. So these are integrative medical practices that are available in communities and in hospitals, and they're available in certain areas. Smaller communities might not have as vast options available. Certainly larger cities would. For this reason, we want to suggest that you investigate things on your own and certainly consult with your medical provider before initiating anything that's a non-pharmacological option to make sure that it's not going to contradict what is being done in your other plan of care. The two need to be able to fit well together, not causing harm or exacerbating the results of what you're currently doing. But you want them to go together and blend very well together and work synergistically together. So as far as non-pharmacological pain therapy, this refers to interventions that are often called complementary medicine. So they're integrative medicine. Integrative medicine does not involve the use of medications to treat pain. The goals of non-pharmacological pain therapy would be to decrease the fears, decrease the distress that the person is experiencing, a lot of times decrease the anxiety that the person is experiencing. And by doing all of that, it reduces pain. And by reducing pain and doing all those other issues like decreasing fear, anxiety, and distress, it restores a sense of control for that individual. So when looking at the person as in a holistic being, one plays a role in the other, plays a role in the other. So they complement one another and work together in an integrative way. So these approaches can help an individual to feel more in control. It will help reduce the feelings of weakness. It will help enhance the functional capacity and their activity level if their pain is better controlled. It will help reduce anxieties and stress, and it will help decrease the pain behavior and the subjective reporting of their pain levels. And it may, in fact, help decrease the dosages required of analgesic medications by using alternative methods that work in conjunction with that medication. Nancy, I think, is complementary therapy where you begin?
Yes, thank you, Rachel. So anyone that really knows me well knows how much I absolutely love complementary medicine and music therapy in particular. And when you look at the science of the physical response to music therapy, there is relatively new endeavor, and there is still a lot to learn about how the body reacts to it. But recently, studies have shown music therapy aids by exposing the patient to different rhythms that actually increase our immunity, and also to reduce the levels of cortisol, of the stress hormone. So from our heartbeats to our brains, to our brain waves, we are naturally hardwired with rhythm, and it's only natural that we respond to the beats in music. So blood pressure is probably one of the best examples that I can think of. Listening to calm music can relax all muscles in your body, actually including the heart. So we'll talk a little bit about acupuncture. And acupuncture actually originated in China, now practiced along with Western medications in several hospitals around the world. Disposable, really thin stainless steel needles are used. They actually, if you look closely at them, they're almost as thin as a strand of hair. They're very tiny. And I always tell people that they're just sitting under the skin. You're not being deeply probed with an acupuncture needle, unless, of course, you're having sciatic pain or something of that nature. And then it is a deep probe with those acupuncture needles. But the benefits of acupuncture go beyond conditions to help with relaxation and pain management. And it can be helpful also as an analgesic. Memorial Sloan Kettering Cancer Center out of New York actually have an insert on their home portal for their patients that patient care where they can access this portal. It even gives all the acupressure points and how to work those acupressure points. So I think that's quite an advancement forward. Reflexology. One reflexology session can stimulate more than 7,000 different nerve endings. I was amazed by that. And I don't know how many of you people actually have experienced reflexology, but it has to be one of the most relaxing treatments that you can have. So it can be done both on your feet and your hands. And those points actually connect to internal organs through the nervous system. And often it's used with women that are laboring as well. It's becoming much more popular. I think that is a good time to mention, though, that when we're talking about complementary therapy, that's exactly what it is. It's a complement to the regular medicine that you would be using. And Reiki, I actually had a quote with Reiki that it's a treatment that feels like a wonderful glowing radiance that flows through and around you, creating many beneficial effects that include relaxation and feelings of peace, security, and well-being. And people have reported it as being actually miraculous to them. The important thing that I think we really need to know and pay attention to with Reiki is when you engage in Reiki, you are taking some responsibility of the purpose of that Reiki, meaning that you're taking responsibility to help heal yourself and your spirit and your emotional well-being when you engage in Reiki. And that's really important that people understand that they do have an active role in Reiki, even though you're really just lying there and you feel like someone's kind of manipulating your energy with their hands, but you do have you are committed to that spirit. Aromatherapy is the practice of using essential oils for therapeutic benefit, and it has been used for centuries and centuries. When inhaled, those scent molecules and essential oils actually travel from the olfactory nerve directly to the brain, so right to the amygdala, and which is, of course, the emotional center of the brain. And again, another study, and this was through John Hopkins Bloomberg School of Public Health. It's old. It was done in 2018, but the professor is still looking for more research toward his work. And he found that the essential oils from garlic, myrrh, thyme leaves, cinnamon bark, allspice berries, and cumin seeds showed a strong killing activity against a slow growing form of a type of Lyme. Those represented really, I would say, really early research, but he is still working toward more properly designed clinical trials. I thought that was super interesting as well. Massage therapy is something most of you likely have a better understanding of, and it's used to help manage health conditions or also to enhance your wellness. And it involves manipulating the soft tissues of the body. Massage has been practiced again in most cultures, both Eastern and Western, throughout human history. Very early to help people feel better. So when you really think about, even when your children are young and you scoop them up when they've been hurt and you're rubbing them, really what you're doing is massaging the tissue. That is massage, right? So the massage therapist varies the amount of pressure and the movement, but overall they're rubbing and kneading the skin and the muscles and really any of those soft tissues. So even the tendons, ligaments, and connective tissue. And medical providers may recommend massage therapy to help people cope with the pain and stress of conditions such as cancer, heart disease, stomach problems, and fibromyalgia. Whereas often, for many, many years, when we thought about massage therapy, it often was someone that has gone to see physiotherapy, they've done what they can, and they'll refer them on to massage therapy. So that could be someone that hurts their back or has a physical strain. But now we're seeing that used for many, many more things than physical strain. And I'll pass it over to Rachel, and she'll talk to us about how being in a proper position is helpful.
Thanks, Nancy. So Nancy touched on some particular therapies in which you would go out to a specific clinic and actually take part in that discipline in order to help alleviate your pain. Some of the things that I'll talk about next are things that you can do in your own home. And the majority of them don't have any cost to them at all. And they're very easy and accessible, and things that we as service providers don't always think about. But as we're addressing the needs of our palliative patients, there are things that we can do some health teaching about that are very easily done by their loved ones that are helping look after them. Or even if they don't need someone looking after them at the present time, we can instruct them on things that might help with their pain control. So positioning is one thing that is a lot of times overlooked. So maintaining proper body alignment can reduce the stress and anxiety, especially in children. Sometimes it can help prevent further complications and can reduce the risk of developing further injuries. Positioning can also help with blood circulation. If you think about, bending your legs or sitting in a chair with your knees at a 90-degree angle for a long period of time, sometimes that can cause increased pain if you've got compromised circulation, pain in your lower limbs. So elevating them and stretching out those legs so that they're not crooked any longer is an easy fix that might help relieve some pressure in those extremities. If someone has pressure sores or is at risk of developing pressure sores, frequent repositioning and getting off those bony prominences can certainly be helpful. And positioning can help relieve muscle pain, tension, and discomfort. And as I already said, elevating extremities. One key thing too, by elevation, it can relieve swelling. The elements of using hot or cold. Often when we're dealing with people who are experiencing some discomfort, we can ask them, have you tried heat? Have you tried cold? And just because heat typically may be something that helps in a certain situation, it may not work for that individual. They may appreciate more cold. So trying either or sometimes is helpful. And so when you think about cold therapy, the concept behind that is it involves putting a cool substance, and it could be moist coolness, or it could be a dry cool from the freezer, like a hot cool pack of some sort, or just dipping the extremity in some cool water. It could involve, putting that cold sensation, that cold product on for about 15 to 30 minutes, 2 to 3 times a day to help relieve that discomfort. It helps to increase the pain threshold, it helps decrease swelling, and it helps decrease inflammation. And then heat, on the other hand, stimulates the receptors in the skin and in the deep tissue, which can help reduce pain if it's going to be helpful in that situation. It helps reduce the muscle spasms that are taking place. It minimizes their excitability and reduces the tension that those muscles might be experiencing, helps relax them so that they're not as tense. And that's how the pain relief is triggered, by that relaxation of those muscles. Sometimes by warming joints, it reduces the viscosity of the synovial fluid, which alleviates some pain and stiffness that can be caused by people who are having pain related to that. And this instance kind of reminds me of, if you have olive oil in a jar in the cupboard, you can see through it and it's very fluid, like a fluid. If you put it in the fridge and it gets cold, it thickens up and you can no longer see through it and it doesn't pour or run anymore. But as soon as you warm it up, then it's more viscous. I think of that along the lines of this with the synovial fluid. By warming it, you're making that fluid a little more viscous so that joints can move a little bit more easily because the fluid is thinner. One thing to keep in mind when you're using heat is you want to make sure that you avoid burns. So if you're using those wheat packs, those hot packs that go in the microwave, don't overheat them, because for one thing, they can catch on fire, but also you don't want to heat them too hot and then put them right on that site that you want the pain relief on, because you could leave a burn. Also, you want to make sure you're using electrical heating pads that have automatic stops versus stay on for long periods of time, because you don't want to create burns on the skin. Sometimes it's helpful to have another product in between the skin and the heating device so that the heating device is not directly on the skin. And you want to be very careful if the person is non-communicative and isn't able to tell you if something is too hot. You need to test it yourself before you're putting it on them. Another option to use are TENS, and I think most of you have probably heard of things like these. They're very easily found in drugstores. You can get them on Amazon, you can get them at specialty shops, and they're called transcutaneous electrical nerve stimulation devices. So they're battery-powered devices. They have 2 to 4 leads depending on what kind it is, and they have sticky pads on the end of these leads that you put on the painful areas. And so you put the pads on, turn the device on, and it delivers a very low voltage of an electrical impulse through the wires onto the padded surface into the painful site. And it produces an analgesia type of response by triggering those nerve fibers. And as I said, these are devices that you can purchase and just use in the comforts of your own home. They have minimal side effects, and they're very, very easy to use. You can pack them up in your bag and take them with you when you're going different places as well. So it's not something that needs to be used in a particular place. Especially helpful for those that have chronic pain sort of issues like arthritis, neuropathic pain, chronic back pain, things like that. You want to be cautious when you're using TENS for those that have cardiac pacemakers or a history of cardiac arrhythmias. And like everything, it's important to check with your medical provider to make sure that what you're doing as alternatives are appropriate, knowing your full history. Distraction is another option that we often don't think about or overlook. And that's really about engaging in thoughts or activities that distract you from that constant, incessant pain that's on your mind. So it's about doing different things that can help you take your mind off that physical pain that you're experiencing. So sometimes things like music might be helpful. Relaxation is a form of distraction. There are many clinical studies that are a little bit inconclusive as to how distraction specifically works. However, it's a technique that you could try. If it works, fabulous. If it doesn't, that's okay as well. There are many different forms of distraction. Relaxation, as I said, is one of them. And that's basically when you try and bring the body into a relaxed state. You want to slow the breathing down, you want to lower the blood pressure, and subsequently that helps lower the heart rate. So relaxation is the opposite of that stress response, that fight or flight response. So you're bringing that body down to a slower level. It's almost like cognitive behavioral therapy, where you're using your mind to control what your body is doing. Guided imagery can also be another way of doing relaxation. And that's when you're focused on something positive, focused on a picture, focused on an experience, you're thinking back. And by doing that, it creates this distraction and helps with that perceived pain. Biofeedback is another type of relaxation technique, which helps you learn how to control functions such as your heartbeat, your blood pressure, muscle tension, to reduce pain. So again, it's a matter of using your mind to control what your body is doing to relieve that pain. Meditation is another example of a type of relaxation technique. And this allows you to use your mind and your body to improve your overall sense of well-being. Breathing exercises are another way of using relaxation. It helps you slow your breathing down, slow your respirations, which in turn will lower your heart rate. And it's about thinking of using your diaphragm to breathe. It's about consciously taking air in through your nose, out through your mouth, feeling that air fill your lungs, feel your rib cage elevate and extend out, and then letting that breath out again. And doing it in a timed manner so that it's slow, repetitive, and rhythmic. So it helps you relax you. If someone is very, very anxious and they're breathing very rapidly, you can do breathing exercises to try and calm all of that down. Hypnosis is also another option for a different relaxation technique. It's when you're working with a specific individual, you're in a trance-like state that helps you go into this deep relaxation type of state to relieve your pain. Some relaxation techniques are very helpful with children and adolescents who have pain, or those that are experiencing anxiety and depression or headaches, or even some that have difficulties with phobias of some sort. It helps you address some of the fears that you may have, allows you to be in that relaxation sort of state to address what it is that needs to be done. There is a lot of supported research, but as I said already, it's not as high quality as we would like. However, these are techniques that don't have an awful lot of side effects. And if it works, give it a try. If it works, fabulous. If it doesn't, try another option. The risks sort of outweigh the benefits with some of these things. And because they don't have fees associated with it, there really is not a loss if it is not overly effective. So relaxation techniques are generally considered safe for healthy people. As I said, negative side effects. And there have been some rare reports that certain relaxation techniques might worsen symptoms in people that have epilepsy or certain kinds of psychiatric conditions, especially if you're using reflective sort of relaxation techniques. It may trigger reflections of abuse and trauma that may exacerbate what they're experiencing at that time. So caution as far as those situations go. Relaxation techniques might be helpful after when someone's experiencing pain after surgery, low back pain, arthritic related pain. In 2017, the Society for Integrative Oncology updated its clinical practice guidelines to include relaxation techniques as therapies for breast cancer treatment. They found that it helped to improve the mood and depression of those that are going through treatment, and that it helped reduce stress and anxiety to control their nausea and vomiting during chemotherapy, which are interesting ideas. We have to always think about the experience of pain can come from a number of different reasons. And so that person's pain may come from anxiety and depression that they're experiencing, or their low mood. It could come from other issues besides a physiological issue or a physiological injury. And so in using a lot of these adjuvant therapies, you're addressing that person as a holistic individual, not just someone who has a physiological injury that requires a medication to help treat it. In one of our other sessions, we talked about total pain. Total pain is not just the physiological pain, it's the pain that comes from stress, the pain that comes from anxiety, the pain that comes from depression. And when you're experiencing all of those things on top of physiological pain, it can exacerbate that sensation, that feeling of pain, because you have all these other stressors that are compounding you. So by using some of these alternative interventions on top of your analgesics, you can maximize the benefit of pain control.
That was excellent, Rachel. That was excellent. And I think it really helps us understand why we use complementary therapy, right? So relaxation is a large part of it, and it helps to control stress, which can cause headaches and muscle tightness. And while analgesics can relieve a headache, they do not address the stress that may have triggered that headache to begin with. So it's our role as PPSMC to educate providers on the need to reassess the source of the pain rather than to actually mask the pain. And why do we use non-pharmacological? These therapies can treat the pain as an adjunct or complementary. And the role of non-pharmacological approaches to pain management truly is evolving. There's lots of evidence to support the use of patient education, relaxation, music, and other modalities as well. So these therapies should be taken into consideration to help and to support the standard pharmacological treatment in pain management. So let's not forget. I think we can move ahead one slide, Rachel. I think I might address most of it. Yeah.
Thank you.
Thank you. So research on the biology and the neurobiology of pain has given us a relationship between spirituality and pain. And, you know, sometimes we're not always comfortable talking to our clients about faith, religion, spirituality, but it is a large, and often it is a large part of their ability to manage pain. I do believe that it is definitely something that we do need to address. And when we think back in history, so Aristotle in 4th century BC described pain as an emotion, being the opposite of pleasure. And it was that simple. So emotions certainly play an important role in our pain perception, but we know that there is much more involved in the process. So spiritual health is actually a predictor of how well someone will accept their pain. So just before I hand it back to Rachel again to get us started on our case studies, I just want to mention how very important it is for us to build really strong, trusting relationships that really aid our providers in the ability to recognize and advocate for the interventions that best suit our patient, including both recognizing when we should refer them on to the appropriate professional and how we go about doing that. So I'll pass it over to Rachel. We'll get started on some case studies. We'll learn a little bit more about how that works.
Thanks, Nancy. So let's meet Judy. Judy is a 32-year-old female. She's a single mom with 2 children. Her children are 6 and 4. She was diagnosed with stage 4 breast cancer in the last year. She had a radical mastectomy on the right breast with a complete lymph node dissection and radiation treatment. She's currently undergoing chemotherapy. Her ESAS scores of note are nausea, 8 out of 10, pain, 8 out of 10, her overall well-being, a 10 out of 10. Let's consider some of the possible non-pharmacological interventions that may assist Judy in her pain control. So I've just listed just a few here, but we definitely did talk about a number of different options available or that Judy could try. So let's consider any of the above treatments or any of the ones that we've spoken about earlier. How could Judy incorporate some of these treatments into her routine? And what barriers or limitations could be present in trying to utilize any of those? So if we think about acupuncture or aromatherapy, music therapy, massage. I'll go back to Judy's case so that you can see it. If you recall, stage 4 breast cancer in the last year, radical mastectomy, and her nausea is 8, her pain is 8, and her overall well-being rated as a 10, very concerning. What could she try? And why could she try it? How could it help?
We have in the chat reflexology. Could reflexology help her in aiding with the nausea? And we also have acupuncture.
Exactly. Yep. Perfect. What would be some of the limitations in trying to utilize some of those therapies for Judy? She's a single mom. She has 2 children, 6 and 4. She might have to go out of her home or go to a clinic to be able to access those resources. Most likely those resources would have a fee associated with them as well. Does she have benefits that could cover that?
So we have a lot of the kids, the cost, time to access, and then we have a great point of music therapy could involve the kids as well as her.
Great idea.
Yeah, and then finances and childcare also could be a hindrance.
Exactly. My suggestion always too is a lot of the community hospices, the visiting hospice programs, or even the residential programs have resources available to individuals who have a palliative diagnosis or a life-limiting illness. So this could be something that could be investigated to see if there are programs that come with a very low fee or even no fee at all to be able to allow her to access some of those services. What about even through her cancer program? There might be some options available that she could access. Do you think there's a component of total pain here? If she indicates her overall well-being is a 10, and we know well-being doesn't just consist of your physical pain.
Yes, we're getting some yes messages.
Yeah. And certainly being a single mom, a recent cancer diagnosis, a huge surgery. I would expect she's probably off work or been off work. What are her social supports like? So we definitely want to be talking to her about who is in her circle. Who can she rely on? Who has she relied on? To see if there's any external other providers that could be involved in her plan, in her circle of people that could assist and relieve some of the stressors that may be contributing to this total pain that she may be experiencing.
Absolutely. Kathy made a great point that there's big issues of accessibility to these types of programs in rural Manitoba.
100%. Thank you for sharing that. Ontario, exactly the same, no different. And a lot of times the small rural communities have no programs such as this, and definitely transportation into the city from those rural locations there is none. A lot of times city transportation doesn't go to the outskirts. So if that's what you rely on, it's not available. Or if she was not even feeling well enough to drive herself, how could she get there?
And I got another direct message looking into whether or not her community provides any type of respite care. So through a community hospice or anything like that.
That's a great point.
Exactly. To relieve, give her a little bit of a break from looking after the children, even if it's a few hours here and there, to prioritize her personal self. Might help her feel a little bit revived, rejuvenated, to be able to come back and be present as that mom again. But knowing her children are looked after. Great thoughts. Any other thoughts before we go to the next case? All right, we are going to meet Gina. Gina is a 48-year-old woman. She's been diagnosed with mental illness and is morbidly obese. She comes into the emergency department frequently by ambulance, usually in the middle of the night. She's complaining of pain and always wearing sunglasses. Gina lives alone and has no family physician. She has pain that's not well described. She describes it as, "I'm sore all over," and is pointing to her joints. Not just one joint, but all of her joints. During her previous visit to the ER, she has been aggressively, verbally, and physically abusive with staff. She's been labeled as a frequent flyer who is drug seeking. Unfortunately, Gina's medical treatment in the ER is not optimum, and she's usually discharged with little investigation or treatment. She currently does not have anyone who can advocate for her. This is a very complex situation. What comes to mind when you hear Gina's story? Before we even think about what options might be available to her, what comes to mind? I'll give you some hints. I think bias. I think labeling. I think she's...
We have some comments here. We have that she's been stigmatized.
Yeah.
And then another one is to get her set up with a social worker, someone who can advocate on her behalf. And
Love
then
that.
also that they're just bad providers.
Yes, unfortunately there are. And the world is filled with bias. And as service providers, it is our responsibility to be sure that we lead by example, to be aware of the biases that we have, so that we're not doing these type of things in our practice directly or even indirectly by avoiding or ignoring. Sometimes that in itself can be just as harmful. So social work was named as one intervention that we can link with Gina to see if there's some assistance that could be provided. What other options can we consider for Gina? She has pain, not well described, sore all over. She also has a history of some mental instability, and she is morbidly obese. No family doctor, so limited supports for prescribing or for healthcare provision in the community. And she lives alone. Do you think there might be some financial issues that are contributing to her issues that she's showing up to the Emerge with?
So here's a comment. Maybe she's continually going to the ER because nothing is being done about her symptoms. So the symptoms keep reoccurring. Must be very frustrating, especially since it sounds like there may be some social isolation, may be related to the mental health issues, and she has no one to advocate for her.
Bang on. Great ideas.
If we could give a gold star to that one, we definitely would.
Exactly. What could be some things that might help Gina that we talked about? What about positioning? Obviously, I'm sure, she probably has quite a sedentary lifestyle. The fact that she has to come in to the Emerge by ambulance, her mobility is probably very compromised, and that might be contributing to her feeling sore all over. We could, see if there are some resources within the community. Is there a special surface that she could be sitting on that might be helpful? Is there a specific surface that she could have that she should be sleeping on versus what she's currently on that might help with some of her discomfort? I expect she probably is long periods of time either in bed or in a chair.
We also have a comment here that she may be scared, not knowing what's going on with her, and that she's never getting the answers.
Exactly. And that could exacerbate. It doesn't specifically say what some of her mental illness stuff is, but there could be a bit of anxiety underlying there where she sort of panicked, calls the ambulance and goes in. That feeling of isolation, not having supports in the community, can exacerbate that pain that you're feeling, that total pain. What about a consult for a dietitian to assist with that possibly some of the control issues that she may have that have led maybe to her obesity. What about the kind of care that we should be providing when someone has constantly been labeled or being discriminated against for whatever reason? As service providers, and what I'm trying to allude to is trauma-informed care. So as service providers, it's important for us to provide care that is trauma-informed, that's not going to continue to trigger Gina and exacerbate her symptoms that she already has. Have people heard of that in the past and how it's effective?
So
Nancy,
Laura,
go ahead.
oh, sorry. Oh, Laura said the same as you with the viewing the case through a trauma-informed care lens. And then also Kathy says there's an issue with finances for groceries. So she needs to be guided on how to buy realistically healthy foods.
Exactly.
Another point from Katrina is even a natural path to discuss foods that can cause inflammation and others that may help with pain relief for the joints, but could be a significant cost. There could be a cost to this.
Yeah, love that idea. Never thought of that, but certainly now that you mention it, I have heard of that, but I hadn't even thought of that. So great ideas. I love these ideas. One thing I want to mention too, and maybe go ahead, Nancy.
Sorry, Rachel. I just wanted to mention quickly that within Palliative, we talk about compassionate communities. And I think it's a really good time to remind people that Palliative has a wonderful website. Compassionate communities absolutely help people just like this. So if you're out in Manitoba or you're out on the East Coast, we're in Central Ontario, but I know Northern Ontario really has a lot of issues with accessibility as well. I just think it's a good time to put a little bit of a note in there to say, take a look at the website within Palliative for compassionate communities, and perhaps there's more that we can do than what we would actually do. The other thing I want to make right back to you is the ability to work online for those communities that are marginalized. Because when we speak of naturopaths or therapists that perhaps can do some online work, this poor woman, 48 at home, having to travel back and forth to the emergency room repeatedly, I wonder if there isn't one person, one social worker that would be able to make things happen for her that are accessible through online materials. Rachel, I'll put it right back to you. I just wanted to get my little bit in there.
No, yeah, great points, Nancy. And I like the idea of even if it's one person and that one person can make the difference. Sometimes it's about having one lifeline. And by the sounds of the scenario with Gina, she doesn't even have one. And so her lifeline is basically going into the emergency room because she's in crisis and she really has no other place to turn. But if there was some sort of resource that could be linked with her as that lifeline, might provide her with that little bit of something to allow her to have a little bit of forward movement and some positive experiences. We tend to migrate towards the medical model of a medication as a quick fix. As we talked about, a lot of these other alternatives have a cost factor, require transportation, but there is something to be said about having that community support, that resource, that friend, or even that individual who you could speak to on a regular basis to make you feel less isolated, less alone, because those feelings of isolation can exacerbate feelings of being out of control and just exacerbate the pain that she may be experiencing. And she's, basically crying out or screaming, every time she comes into the emergency room, she's crying out for help. And so if we can, go to the root of what it is that's making her feel that way, we can help provide some resources in the community so that she doesn't feel she needs to come into that emergency room. Any other?
There's a couple more comments. a very sweet one from Kathy saying that if she lives in her area, send her to her because she can help her. So thank you, Kathy. And then another one from Sherry Ann saying, not sure if anyone has said this already, but a community volunteer could be very helpful.
Awesome. Such a great idea. Yes. Yeah. It's that companionship sometimes, right? That break in the day, something to look forward to. It almost acts as a distraction almost. And I would expect that when she is present with a volunteer or present speaking to someone, maybe the pain isn't quite as bad because it acts as that distraction that we spoke about. You're thinking about something different. So instead of alone in your own thoughts, thinking about the glass is half empty, it's about refocusing and thinking about what is positive. Not certainly something that can be fixed right away, but there are certainly some resources that might be valuable. And it's about looking at the entire picture and making her and allowing her to feel heard and not contributing further to the inadequacies that she's feeling. One thing I'd like to mention as well, there are social determinants of health that really underlie many communities, many individuals in communities, many vulnerable populations that we don't even realize are hindering compliance with plans of care. They hinder the way people respond to different therapies. And sometimes it's about digging down deep, not just at the surface, but digging down deep as to what the source of some of these triggers might be and what is influencing the thing that we're seeing on the surface, because it might not just be the surface issue that we need to address. We don't want to do the bandage fix. We want to be able to get to the root of it so that healing can take place. And healing from a palliative perspective is not looking for a cure, it's looking for improvement in that quality of life. And so by using adjuvant therapies, those non-medical options, some with a fee, some without a fee, that we tend to overlook, might be very, very valuable in contributing to an improvement in that experience, an improvement in the quality of that experience. Are there any other thoughts in the chat there, Amanda?
Nope, not at this time.
All right, I will move forward. And there is our QR code for the survey. I would love it if all of you could complete that for us. It helps us improve our ongoing in-services as we move forward into the new year. We'll have some new ideas coming forward.
We do have one question that's not related to the case studies.
Sure.
So it was basically every time someone recommends the complementary therapies that they're kind of poo-pooed on, how do you address that? And how do you try to get people to see past their initial bias about the complementary therapies?
So the way I'm understanding that is, if you're bringing say you're going in and you're seeing your medical prescriber and you're speaking to them about, maybe thinking about Reiki or thinking about going to see an acupuncture for some pain control. And you're just kind of asking them for their support or just bringing it to their attention so that you can make sure that it's something that will blend well with the plan that is already being used for you. Is that correct?
That's correct.
Okay. So my thought is, you're not really asking for permission, like as an individual coming in and advocating for your own health and speaking to what would be something you'd like to consider. In a way you're asking permission, but in a way you're not. And so I would approach it with confidence, and I would approach it from the perspective of, this is what I've read about, or this is what I've heard about. What are your thoughts? And then if it gets poo-pooed or it gets, sort of dismissed, you can come back with a question of saying, is there a reason why you think it might not be an option? Or do you have concerns if this was an option I would consider?
So
then asking them to
question,
speak to you about why.
yeah. And then the question is from a HCP's perspective.
I like research. And as much as I involve myself in complementary medicine, when I'm having conversations with healthcare providers, particularly, I like to bring the research with me. So if you are looking to have acupuncture, or you're looking to refer a client for, as Rachel said, a Reiki therapy or music therapy, just get your research together first so that you have that backing. Often that is the ticket to freedom, right? The more we know that has solid research behind it, that the greater chance you're actually going to be listening to.
Thank you. That's great. And there was a couple of mentions about recording of today's session. We will be sending out a follow-up email with a recording, as well as the link to the survey and some other tools that you might find useful. So keep your eyes on your inbox for that. If you don't see it in the next couple of days, check your junk mail, because sometimes it likes to be filtered out. Also, if you missed the first couple of sessions in this series, feel free to check it out online on our Echo page, or you can follow us on YouTube, where we've created playlists so you can watch an entire series back to back to back if you wish. And that our YouTube channel is just under the NSMHPCN. And thank you, Rachel and Nancy, for being here today. This has been a great session, and I'm looking forward to the final one, where we're going to be talking about total concept of pain.
Thanks, Amanda. I see Kathy's hand up. Does Kathy still have a question?
Feel free to unmute yourself, Kathy, if you wanted to chat.
Hi, can you hear me?
Yes.
Okay, so the question was actually, I'm the healthcare provider, HCP is healthcare provider, sorry. I'm a nurse practitioner.
Okay.
And I actually talk to a lot of my clients about alternative care, because I do believe in it. And that I'm an unusual healthcare provider. I do believe in cannabis. I do believe in different modalities, because they do work. I've seen them work. I live with chronic pain myself. But I have clients who are going, no, I can't do that. I mean, we're not supposed to use cannabis. It's frowned on in the church. Reiki, oh, that sounds really weird. I can convince them to do massage. I can convince them for physio. But alternative stuff, they're really not that interested. They don't have enough information, I think, is what the issue is. How do I help them overcome that, and not just to shut me down, not to poo-poo me?
Yeah. So I would, like Nancy said, I'd probably provide them with the literature. I would probably say, the choice is yours, but as your healthcare provider, I think there is value in at least knowing that there are other options that may be helpful. And so, in your role, it's important that you are sharing all options that are available so that they can choose the one that's best suited for them. And here's the literature for it if they would like to read it. Obviously, probably the people that you'll be giving information to are health literate individuals who will understand it and be able to look to that and make sense of it. There are others that maybe don't have that luxury of having that healthcare knowledge or the healthcare language to be able to understand literature like that if you were to give it to them. So then you could just sort of explain it in layman's terms as best you can, but approach it from the perspective of, I'm not pushing it, but I do know firsthand that something like this has been successful in cases that are similar to yours. These are all the different options, but the choice is ultimately yours to make. But here is all the information I can provide to you. So you're unbiasedly providing information and giving the choices.
Thank you. That's a good one. Now I just got to find the literature to back me up.
Yeah, exactly. Yep.
Okay, thank you.
You're welcome.
And when is the next session, by the way?
Is it January, Amanda?
It's January, and then we have the total concept of pain is the final Thursday of January, and then we have an encore presentation, which is on the ESAS in February.
Perfect. It's on our website though. So if you go to the website or click on the echo sessions on the website, the specific January date would be listed there. Awesome. Thanks for joining us, everyone.
Yes, thank you so much. It was a great session.
Thanks, Amanda. Thanks, Nancy. Thanks, everyone. Happy holidays.